Journal of the American Academy of Pediatrics. 0. Clinical Practice Guideline for the Diagnosis and Management of Acute Bacterial Sinusitis in Children aged 1 to 18 years. Ellen R. Wall, Kimberly E. Applegate, Clay Bordley, David H. Darrow, Mary P. Glow. Clinical Practice Guideline for the Diagnosis and Management of Acute Bacterial Sinusitis in Children aged 1 to 18 years. Abstract-free. Objective: to update the American Academy of Pediatrics Clinical Practice Guideline regarding the diagnosis and management of acute bacterial sinusitis in children and adolescents. Methods: analysis of the medical literature published since the last version of the guideline 2001. Results: the diagnosis of acute bacterial sinusitis is made when a child with an acute upper respiratory tract infection URI presents with 1 persistent illness, nasal discharge of any quality, or daytime cough, or both lasting more than 10 days without improvement. 2. A worsening course, worsening or new onset of nasal discharge, daytime cough, or fever after initial improvement. Or 3. Severe onset concurrent fever, temperature 39 degrees C/102.2 degrees F, and purulent nasal discharge for at least 3 consecutive days. Clinicians should not obtain imaging studies of any kind to distinguish acute bacterial sinusitis from viral URI, because they do not contribute to the diagnosis. However, by contrast, enhanced computed tomography scan of the paranasal sinuses should be obtained whenever a child is suspected of having orbital or central nervous system complications. The clinician should prescribe antibiotic therapy for acute bacterial sinusitis in children with severe onset or worsening course. The clinician should either prescribe antibiotic therapy or offer additional observation for 3 days to children with persistent illness. Amoxicillin with or without clavulanate is the first-line treatment of acute bacterial sinusitis. Clinicians should reassess initial management if there is either a caregiver report of worsening progression of initial signs/symptoms or appearance of new signs/symptoms or failure to improve within 72 hours of initial management. If the diagnosis of acute bacterial sinusitis is confirmed in a child with worsening symptoms or failure to improve, then clinicians may change the antibiotic therapy for the child initially managed with antibiotic or initiate antibiotic treatment of the child initially managed with observation. Conclusions: changes in this revision include the addition of a clinical presentation designated as worsening course, an option to treat immediately or observe children with persistent symptoms for 3 days before treating, and a review of evidence indicating that imaging is not necessary in children with uncomplicated acute bacterial sinusitis. Pediatrics 2013, 132, F162, F180. Ellen R. Wall, MD, FOP, Kimberly. Acute bacterial sinusitis is a common complication of viral upper respiratory infection URI or allergic inflammation. Using stringent criteria to define acute sinusitis, it has been observed that between 6% and 7% of children seeking care for respiratory symptoms has an illness consistent with this definition. This clinical practice guideline is a revision of the clinical practice guideline published by the American Academy of Pediatrics AP in 2001.5. It has been developed by a subcommittee of the Steering Committee on Quality Improvement and Management that included physicians with expertise in the fields of primary care pediatrics, academic general pediatrics, family practice, allergy, epidemiology and informatics, pediatric infectious diseases, pediatric otolaryngology, radiology, and pediatric emergency medicine. None of the participants had financial conflicts of interest, and only money from the AP was used to fund the development of the guideline. The guideline will be reviewed in 5 years unless new evidence emerges that warrants revision soon. The guideline is intended for use in a variety of clinical settings, for example, office, emergency department, hospital, by clinicians who treat pediatric patients. The data on which the recommendations are based are included in a companion technical report published in the electronic pages. The Partnership for Policy Implementation has developed a series of definitions using accepted health information technology standards to assist in the implementation of this guideline in computer systems and quality measurement efforts. This document is available at http://www.op.org/informatics/PPI HTML. This revision focuses on the diagnosis and management of acute sinusitis in children between 1 and 18 years of age. It does not apply to children with subacute or chronic sinusitis. Similar to the previous guideline, this document does not consider neonates and children younger than 1 year or children with anatomic abnormalities of the sinuses, immunodeficiencies, cystic fibrosis, or primary ciliary dyskinesia. The most significant areas of change from the 2001 guideline are in the addition of a clinical presentation designated as worsening course, inclusion of new data on the effectiveness of antibiotics in children with acute sinusitis, and a review of evidence indicating that evidence quality: A. Well-designed RCTs or diagnostic studies on relevant population. B. RCTs or diagnostic studies with minor limitations, overwhelmingly consistent evidence from observational studies. C. Observational studies, case, control, and cohort design. Imaging is not necessary to identify those children who will benefit from antimicrobial therapy. Methods: the Subcommittee on Management of Sinusitis met in June 2009 to identify research questions relevant to guideline revision. The primary goal was to update the 2001 report by identifying and reviewing additional studies of pediatric acute sinusitis that have been performed over the past decade. Searches of PubMed were performed by using the same search term as in the 2001 report. All searches were limited to English, language, and human studies. 3 separate searches were performed to maximize retrieval of the most recent and highest quality evidence for pediatric sinusitis. The first limited results to all randomized controlled trials RCTs from 1966 to 2009, the second to all meta-analyses from 1966 to 2009, and the third to all pediatric studies limited to ages 18 years published since the last technical report 1999-2009. Additionally, the Web of Science was queried to identify studies that cited the original AP guidelines. This literature search was replicated in July 2010. Preponderance of benefit or harm, strong recommendation, balance of benefit and harm option, recommendation. D. Expert opinion, case reports, reasoning. Results of the literature review are published separately in the technical report. In summary, 17 randomized studies of sinusitis in children were identified and reviewed. Only 3 trials met inclusion criteria. Because of significant heterogeneity among these studies, formal meta-analyses were not pursued. The results from the literature review were used to guide development of the key action statements included in this document. These action statements were generated by using Bridge, was building recommendations in a developer's guideline editor, Yale School of Medicine, child with an acute URI presence with the following. KES Profile 1. Aggregate evidence quality, persistent illness, i.e., nasal discharge of any quality or daytime cough or both lasting more than 10 days without improvement. Worsening course, i.e., worsening or new onset of nasal discharge, daytime cough, or fever after initial improvement, or severe onset, i.e., concurrent fever temperature 39 degrees C/102.2 degrees F and purulent nasal discharge for at least 3 consecutive days. Evidence quality. B. Recommendation. Diagnosis allows decisions regarding management to be made. Children likely to benefit from antimicrobial therapy will be identified. Inappropriate diagnosis may lead to unnecessary treatment. Misdiagnosis may lead to persistent infection or complications. Inappropriate diagnosis may lead to unnecessary cost of antibiotics. Misdiagnosis leads to cost of persistent illness, loss of time from school and work, or cost of caring for complications. Preponderance of benefit, none. Limited, none. Children aged 1 year or older than 18 years and with underlying conditions. Recommendation. Statement strong recommendation. Recommendation. Option. No recommendation. Definition. A strong recommendation in favor of a particular action is made when the anticipated benefits of the recommended intervention clearly exceed the harms, as a strong recommendation against an action is made when the anticipated harms clearly exceed the benefits and the quality of the supporting evidence is excellent. In some clearly identified circumstances, strong recommendations may be made when high quality evidence is impossible to obtain and the anticipated benefits strongly outweigh the harms. A recommendation in favor of a particular action is made when the anticipated benefits exceed the harms but the quality of evidence is not as strong. Again, in some clearly identified circumstances, recommendations may be made when high-quality evidence is impossible to obtain but the anticipated benefits outweigh the harms. Options define courses that may be taken when either the quality of evidence is suspect or carefully performed studies have shown little clear advantage to one approach over another. No recommendation indicates that there is a lack of pertinent published evidence and that the anticipated balance of benefits and harms is presently unclear. Implication. Clinicians should follow a strong recommendation unless clear and compelling rationale for an alternative approach is present. Clinicians would be prudent to follow a recommendation, but should remain alert to new information and sensitive to patient preferences. Clinicians should consider the option in their decision making, and patient preference may have a substantial role. Clinicians should be alert to new published evidence that clarifies the balance of benefit versus harm. Ep 164 from the American Academy of Pediatrics, downloaded from www.applications.org/news by 9/6. The purpose of this action statement is to guide the practitioner in making a diagnosis of acute bacterial sinusitis on the basis of stringent clinical criteria. To develop criteria to be used in distinguishing episodes of acute bacterial sinusitis from other common respiratory infections, it is helpful to describe the features of an uncomplicated by nasal symptoms, discharge, and congestion/obstruction or cough or both. Most often, the nasal discharge begins as clear and watery. Often, however, the quality of nasal discharge changes during the course of the illness. Typically, the nasal discharge becomes thicker and more mucoid and may become purulent, thick, colored, and opaque for several days. Then the situation reverses, with the purulent discharge becoming mucoid and then clear again or simply resolving. The transition from clear to purulent to clear again occurs in uncomplicated viral URIs without the use of antimicrobial therapy. Fever, when present in uncomplicated viral URI, tends to occur early in the illness, often in concert with other constitutional symptoms such as headache and myalgias. Typically, the fever and constitutional symptoms disappear in the first 24 to 48 hours, and the respiratory symptoms become more prominent. Fig 2. The course of most uncomplicated viral URIs is 5 to 7 days, 9-12 as shown in Fig 2. Respiratory symptoms usually peak in severity by days 3 to 6 and then begin to improve. However, resolving symptoms and signs may persist in some patients after day 10,810. Symptoms of acute bacterial sinusitis and uncomplicated viral URI overlap considerably, and therefore it is their persistence without improvement that suggests a diagnosis of acute sinusitis. 91,013. Such symptoms include Pediatrics Volume 132, Number 1, July 2013. Nasal discharge of any quality, thick or thin, serous, mucoid, or purulent or daytime cough which may be worse at night or both. Bad breath, fatigue, headache, and decreased appetite, although common, are not specific indicators of acute sinusitis. 14. Physical examination findings are also not particularly helpful in distinguishing sinusitis from uncomplicated URIs. Erythema and swelling of the nasal turbinates are non-specific findings. 14. Percussion of the sinuses is not useful. Transillumination of the sinuses is difficult to perform correctly in children and has been shown to be unreliable. 1,516. Nasopharyngeal cultures do not reliably predict the etiology of acute bacterial sinusitis. 14.16. Only a minority till the 6%, 7% of children presenting with symptoms of URI will meet criteria for persistence. 3, 4, 11. As a result, before diagnosing acute bacterial sinusitis, it is important for the practitioner to attempt to 1. Differentiate between sequential episodes of uncomplicated viral URI which may seem to coalesce in the mind of the patient or parent from the onset of acute bacterial sinusitis with persistent symptoms, and 2. Establish whether the symptoms are clearly not improving. Worsening course of signs and symptoms, termed double sickening, in the context of a viral URI is another presentation of acute bacterial sinusitis. 13.17 Affected children experience substantial and acute worsening of severity. Figure 2. Uncomplicated viral URI. Respiratory symptoms: fever. 7, 8, 9, 10, 11, 12 days. Respiratory symptoms: nasal discharge or nasal congestion or daytime cough or a new fever, often on the 6th or 7th day of illness, after initial signs of recovery from an uncomplicated viral URI. Support for this definition comes from studies in children and adults, for whom antibiotic treatment of worsening symptoms after a period of apparent improvement was associated with better outcomes. Finally, some children with acute bacterial sinusitis may present with severe onset, i.e., concurrent high fever temperature 39 degrees C and purulent nasal discharge. These children usually are ill-appearing and need to be distinguished from children with uncomplicated viral infections that are unusually severe. If fever is present in uncomplicated viral URIs, it tends to be present early in the illness, usually accompanied by other constitutional symptoms, such as headache and myalgia. 9, 13, 18 Generally, the constitutional symptoms resolve in the first 48 hours and then the respiratory symptoms become prominent. Most uncomplicated viral infections, including influenza, purulent nasal discharge does not appear for several days. Accordingly, it is the concurrent presentation of high fever and purulent nasal discharge for the first 3 to 4 days of an acute URI that helps to define the severe onset of acute bacterial sinusitis. 13, 16, 18 This presentation in children is the corollary to acute onset of headache, fever, and facial pain in adults with acute sinusitis. Allergic and non-allergic rhinitis are predisposing causes of some cases of acute bacterial sinusitis in childhood. In addition, at their onset, these conditions may be mistaken for acute bacterial sinusitis. A family history of atopic conditions, seasonal occurrences, or occurrences with exposure to common allergens and other. Downloaded from www.applications.org/news by 967986 on January 40, 2019 at 165. Allergic diatheses in the index patient eczema, atopic dermatitis, asthma may suggest the presence of non-infectious rhinitis. The patient may have complaints of pruritic eyes and nasal mucosa, which will provide a clue to the likely etiology of the condition. On physical examination, there may be a prominent nasal crease, allergic shiners, cobblestoning of the conjunctiva or pharyngeal wall, or pale nasal mucosa as other indicators of the diagnosis. The action statement 2A. Clinicians should not obtain the MAG in studies, plain films, contrast-enhanced computed tomography CT, MRI, or ultrasonography to distinguish acute bacterial sinusitis from viral URI. Evidence quality. B. Strong recommendation. A is profile 2A. Suspected to have acute bacterial sinusitis, it is no longer recommended. The membranes that line the nose are continuous with the membranes mucosa that line the sinus cavities, the middle ear, the nasopharynx, and the oropharynx. When an individual experiences a viral URI, there is inflammation of the nasal mucosa and, often, the mucosa of the middle ear, and paranasal sinuses as well. The continuity of the mucosa of the upper respiratory tract is responsible for the controversy regarding the usefulness of images of the paranasal sinuses in contributing to a diagnosis of acute bacterial sinusitis. As early as the 1942nd, observations were made regarding the frequency of abnormal sinus radiographs in healthy children without signs or symptoms of aggregate evidence quality. B. Overwhelmingly considered. The purpose of this key action statement is to discourage the practitioner from obtaining imaging studies in children with uncomplicated acute bacterial sinusitis. As emphasized in key action statement 1, acute bacterial sinusitis in children is a diagnosis that is made on the basis of stringent clinical criteria that describe signs. Enhanced CT scan of the paranasal sinuses and /or an key action statement 2B. Clinicians should obtain a contrast-enhanced CT scan of the paranasal sinuses and /or an MRI with contrast whenever a child is suspected of having orbital or central nervous system complications of acute bacterial sinusitis. Evidence quality. B. Strong recommendation. A is profile 2B. Orbital complication. The site of infection remains confined to the sinus cavities. My swelling is attributable to the impedance of venous drainage secondary to congestion within the ethmoid sinuses. Alternative terms for sympathetic effusion inflammatory edema are perceptual or periorbital cellulitis. The remaining true orbital complications are best visualized by contrast, enhanced CT scanning. Aggregate evidence quality. B. Overwhelmingly consistent evidence from observational studies. Benefit harm. Cost benefits, harm assessment, value judgments. Role of patient preference, intentional vagueness, exclusion strength. Determine presence of abscesses, which may require surgical intervention. Avoid sequelae because of appropriate aggressive management. Exposure to ionizing radiation for CT scans. Need for sedation for MRI. Direct cost of studies. Preponderance of benefit. Concern for significant complication that may be unrecognized and therefore not treated appropriately. Limited, none. Strong recommendation. The purpose of this key action statement is to have the clinician obtain contrast, enhanced CT images when children are suspected of having serious complications of acute bacterial sinusitis. Most common complication of acute sinusitis involves the orbit in children with ethmoid sinusitis who are younger than 5 years. 2931 Orbital complications should be suspected when the child presents with a swollen eye, especially if accompanied by proptosis or impaired function of the extraocular muscles. Orbital complications of acute sinusitis have been divided into 5 categories: sympathetic effusion, superior osteal abscess, orbital cellulitis, orbital abscess, and cavernous sinus thrombosis. 32. Although sympathetic effusion inflammatory edema is categorized as an intracranial complications of acute sinusitis, which are substantially less common than orbital complications, are more serious, with higher morbidity and mortality than those involving the orbit. Intracranial complications should be suspected in the patient who presents with a very severe headache, photophobia, seizures, or other focal neurologic findings. Intracranial complications include subdural impairment, epidural impairment, venous thrombosis, brain abscess, and meningitis. 29. Typically, patients with intracranial complications of acute bacterial sinusitis are previously healthy adolescent males with frontal sinusitis. 3,334. There have been no head-to-head comparisons of the diagnostic accuracy of contrast, enhanced CT scanning to MRI with contrast in the evaluation of orbital and intracranial complications of sinusitis in children. In general, the contrast enhanced CT scan has been the preferred imaging study when complications of sinusitis are suspected. 3,536. However, there are documented cases in which a contrast-enhanced CT scan has not revealed the abnormality responsible for the clinical presentation, and the MRI with contrast has, especially for intracranial complications and rarely for orbital complications. 37.38. Accordingly, the most recent appropriateness criteria from the American College of Radiology endorse both MRI with contrast and contrast-enhanced CT as complementary examinations when evaluating potential complications of sinusitis. 35. The availability and speed of obtaining the contrast-enhanced CT are desirable. However, there is increasing concern regarding exposure to radiation. The MRI, although very sensitive, takes longer than the contrast-enhanced CT and often requires sedation in young children, which carries its own risks. In older children and adolescents who may not require sedation, MRI with contrast, if available, may be preferred when intracranial complications are likely. Furthermore, MRI with contrast should be performed when there is persistent clinical concern or incomplete information has been provided by the contrast-enhanced CT scan. The action statement 3. Initial management of acute bacterial sinusitis. 3.8. Severe onset and worsening course acute bacterial sinusitis. The clinician should prescribe antibiotic therapy for acute bacterial sinusitis in children with severe onset or worsening course signs, symptoms, or both. Evidence quality. B. Strong recommendation. Pediatrics Volume 132, Number 1, July 2013. Downloaded from www.applications.org/news by 967986 on January 40, 2019. F 467. KES Profile 3A. Aggregate evidence quality. B. Randomized controlled trials with limitations. Benefit harm. Cost benefits. Harm assessment. Value judgments. Role of patient preference. Intentional vagueness. Exclusion strength. Increased clinical cures. Shorten illness duration. And may prevent suppurative complications in a high risk patient population. Adverse effects of antibiotics. Direct cost of therapy. Preponderance of benefit. Concern for morbidity and possible complications. If untreated. Limited. None. None. Strong recommendation. 3B. Persistent illness. The clinician should either prescribe antibiotic therapy or offer additional outpatient observation for 3 days to children with persistent illness, nasal discharge of any quality, or cough, or both for at least 10 days without evidence of improvement. Evidence quality. B. Recommendation. AS Profile 3B. The purpose of this section is to offer guidance on initial management of persistent illness sinusitis by helping clinicians choose between the following 2 strategies. 1. Antibiotic therapy, defined as initial treatment of acute bacterial sinusitis with antibiotics, with the intent of starting antibiotic therapy as soon as possible after the encounter. Aggregate evidence quality. B. Randomized controlled trials with limitations. Benefit, harm, cost, benefits, harm assessment, value judgments, role of patient preference, intentional vagueness, exclusions. Strength, antibiotics increase the chance of improvement or cure at 10 to 14 days. Number needed to treat. 3.5. Additional observation may avoid the use of antibiotics with attendant cost and adverse effects. Antibiotics have adverse effects. Number needed to harm. 3. It may increase bacterial resistance. Observation may prolong illness and delay start of needed antibiotic therapy. Direct cost of antibiotics as well as cost of adverse actions. Indirect cost of delayed recovery when observation is used. Preponderance of benefit because both antibiotic therapy and additional observation with rescue antibiotic, if needed, are appropriate management. Role for additional brief observation period for selected children with persistent illness sinusitis. Similar to what is recommended for acute otitis media, despite the lack of randomized trials specifically comparing additional observation with immediate antibiotic therapy and longer duration of illness before presentation. Substantial role in shared decision making that should incorporate illness severity, child's quality of life, and caregiver values and concerns. None. Children who are excluded from randomized clinical trials of acute bacterial sinusitis, as defined in the text. Recommendation 2. Additional outpatient observation, defined as initial management of acute bacterial sinusitis limited to continued observation for 3 days, with commencement of antibiotic therapy if either the child does not improve clinically within several days of diagnosis or if there is clinical worsening of the child's condition at any time. In contrast to the 2001 AP Guideline 5, which recommended antibiotic therapy for all children diagnosed with acute bacterial sinusitis, this guideline allows for additional observation of children presenting with persistent illness, nasal discharge of any quality, or daytime cough, or both for at least 10 days without evidence of improvement. In both guidelines, however, children presenting with severe or worsening illness which was not defined explicitly in the 2001 guidelines are to receive antibiotic therapy. The rationale for this approach, Table 2, is discussed below. Antibiotic therapy for acute bacterial sinusitis. In the United States, antibiotics are prescribed for 82% of children with Acute sinusitis. 39. The rationale for antibiotic therapy of acute bacterial sinusitis is based on the recovery of bacteria in high-density 104 coloniform units/ml and 70% of maxillary sinus aspirates obtained from children with a clinical syndrome characterized by persistent nasal discharge, daytime cough, or both. 1,640 children who present with severe onset acute bacterial sinusitis are presumed to have bacterial infection because a temperature of at least 39 degrees C/102.2 degrees F coexisting for at least 3 consecutive days with purulent nasal discharge is not consistent with the well-documented pattern of acute viral URI. Similarly, children with worsening course acute bacterial sinusitis have a clinical course that is also not consistent with the steady improvement that characterizes an uncomplicated viral URI. 9. 10. F168 from the American Academy of Pediatrics, downloaded from www.applications.org/news by 967986 on January 40, 2019. From the American Academy of Pediatrics. 3 RCTs have compared antibiotic therapy with placebo for the initial management of acute bacterial sinusitis in children. 2 trials by Wald et al. 441 found an increase in cure or improvement after antibiotic therapy compared with placebo, with a number needed to treat of 3 to 5 children. Most children in these studies had persistent acute bacterial sinusitis, but children with severe or worsening illness were also included. Conversely, Garbutt et al. 42, who studied only children with persistent acute bacterial sinusitis, found no difference in outcomes for antibiotic versus placebo. Another RCT by Crystal et al. 43, often cited as showing no benefit from antibiotics for acute bacterial sinusitis, will not be considered further because of methodologic flaws, including weak entry criteria and inadequate dosing of antibiotic treatment. The guideline recommends antibiotic therapy for severe or worsening acute bacterial sinusitis because of the benefits revealed in R441 and a theoretically higher risk of suppurative complications than for children who present with persistent symptoms. Orbital and intracranial complications of acute bacterial sinusitis have not been observed in RCTs, even when placebo was administered. However, sample sizes have inadequate power to preclude an increased risk. This risk, however, has caused some investigators to exclude children with severe acute bacterial sinusitis from trial entry. 42. Complications is low for 141 symptoms of persistent acute bacterial sinusitis may be mild and have varying effects on a given child's quality of life, ranging from slight mild cough, nasal discharge to significant sleep disturbance, behavioral changes, school or child care absenteeism. Benefits of antibiotic therapy in some trials for 141 must also be balanced against an increased risk of adverse events. Number need to harm. 3. Most often self-limited diarrhea, but also including occasional rash. Choosing between antibiotic therapy or additional observation for initial management of persistent illness, sinusitis presents an opportunity for shared decision making with families. Table 2. Factors that might influence this decision include symptom severity, the child's quality of life, recent antibiotic use, previous experience or outcomes with acute bacterial sinusitis, cost of antibiotics, ease of administration, caregiver concerns about potential adverse effects of antibiotics, persistence of respiratory symptoms, or development of complications. Values and preferences expressed by the caregiver should be taken into consideration. Table 3. Children with persistent acute bacterial sinusitis who received antibiotic therapy in the previous 4 weeks. Those with concurrent bacterial infection, for example, pneumonia, suppurative cervical adenitis, group of streptococcal pharyngitis, or acute otitis media. Those with actual or suspected complications of acute bacterial sinusitis, or those with underlying conditions, should generally be managed with antibiotic therapy. The latter group includes children with asthma, cystic fibrosis, immunodeficiency, previous sinus surgery, or anatomic abnormalities of the upper respiratory tract. Limiting antibiotic use in children with persistent acute bacterial sinusitis who may improve on their own reduces common antibiotic-related adverse events, such as diarrhea, diaper dermatitis, and skin rash. The most recent RCT of acute bacterial sinusitis in children found adverse events of 44% with antibiotic and 14% with placebo. Limiting antibiotics may also reduce the prevalence of resistant bacterial pathogens. Although this is always a desirable goal, no increase in resistant bacterial species was observed within the group of children treated with a single course of antimicrobial agents compared with those receiving placebo in 2 recent large studies of antibiotic versus placebo for children with acute otitis media. 4,445. The action statement 4. Clinicians should prescribe amoxicillin with or without clavulanate as first-line treatment when a decision has been made to initiate antibiotic treatment of acute bacterial sinusitis. Evidence quality. B. Recommendation. Additional observation for persistent onset acute bacterial sinusitis. The guideline recommends either antibiotic therapy or an additional brief period of observation as initial management strategies for children with persistent acute bacterial sinusitis because, although there are benefits to antibiotic therapy, number needed to treat. 3.5. Some children improve on their own and the risk of suppurative KS profile 4. Aggregate evidence quality. B. Randomized controlled trials with limitations. Benefit, harm, cost, benefits, harm assessment, value judgments, role of patient preference, intentional vagueness, exclusion, strength, increased clinical cures with narrowest spectrum drug, stepwise increase in broadening spectrum as risk factors for resistance, increased adverse effects of antibiotics, including development of hypersensitivity, direct cost of antibiotic therapy, preponderance of benefit, concerns for not encouraging resistance if possible, potential for shared decision making that should incorporate the caregivers. Experiences and values. None may include allergy or intolerance. Recommendation. Pediatrics Volume 132. Number 1. July 2013 at 169. Downloaded from www.applications.org/news by 967986. 7986 on January 40, 2019. Table 2 recommendations for initial use of antibiotics for acute bacterial sinusitis. Clinical presentation. Uncomplicated acute bacterial sinusitis without coexisting illness. Acute bacterial sinusitis with orbital or intracranial complications. Acute bacterial sinusitis with coexisting acute otitis media, pneumonia, rhinitis, or streptococcal pharyngitis. Worsening acute bacterial sinusitis. Severe acute bacterial sinusitis. Antibiotic therapy. Persistent acute bacterial sinusitis. Antibiotic therapy or additional observation. For 3 days, antibiotic therapy. Antibiotic therapy. Defined as temperature 239 degrees C and purulent thick, color, and opaque nasal discharge present concurrently for at least 3 consecutive days. Defined as nasal discharge or daytime cough with sudden worsening of symptoms manifested by new onset fever 38 degrees C/100.4 degrees F or substantial increase in nasal discharge or cough after having experienced transient improvement of symptoms. Defined as nasal discharge of any quality, daytime cough which may be worse at night, or both, persisting for 10 days without improvement. Opportunity for shared decision making with the child's family. If observation is offered, a mechanism must be in place to ensure follow-up and begin antibiotics if the child worsens at any time or fails to improve within 3 days of observation. The purpose of this key action statement is to guide the selection of antimicrobial therapy once the diagnosis of acute bacterial sinusitis has been made. The microbiology of acute bacterial sinusitis was determined nearly 30 years ago through direct maxillary sinus aspiration in children with compatible signs and symptoms. The major bacterial pathogens recovered at that time were Streptococcus pneumoniae in approximately 30% of children and non-typable Haemophilus influenzae and Moraxella catarrhalis in approximately 20% each. 16.40 aspirates from the remaining 25% to 30% of children were sterile. Maxillary sinus aspiration is rarely performed at the present time unless the course of the infection is unusually prolonged or severe. Although some authorities have recommended obtaining cultures from the middle meters to determine the cause of a maxillary sinus infection, there are no data in children with acute bacterial sinusitis that have compared such cultures with cultures of a maxillary sinus aspirate. Furthermore, there are data indicating that the middle metis in healthy children is commonly colonized with S. pneumoniae, H. influenzae, and M. catarrhalis. 46. Recent estimates of the microbiology of acute sinusitis have, of necessity, been based primarily on that of acute otitis media AOM, a condition with relatively easy access to infected fluid through performance of tympanocentesis and one with a similar pathogenesis to acute bacterial sinusitis. 47, 48. The 3 most common bacterial pathogens recovered from the middle ear fluid of children with AOM are the same as those that have been associated with acute bacterial sinusitis. S. pneumoniae, non-typable H. influenzae, and M. catarrhalis. 49. The proportion of each has varied from study to study depending on criteria used for diagnosis of AOM, patient characteristics, and bacteriologic techniques. Recommendations since the year 2000 for the routine use in infants of 7-valent and, more recently, 13-valent pneumococcal conjugate vaccine PCV13 have been associated with a decrease in recovery of S. pneumonia from ear fluid of children with AOM and a relative increase in the incidence of infections attributable to H. influenzae. 50. Thus, on the basis of the proportions of bacteria found in middle ear infections, it is estimated that S. pneumoniae and H. influenzae are currently each responsible for approximately 30% of cases of acute bacterial sinusitis in children, and M. catarrhalis is responsible for approximately 10%. These percentages are contingent on the assumption that approximately 1/4 of aspirates of maxillary sinusitis would still be sterile, as reported in earlier studies. Staphylococcus aureus is rarely isolated from sinus aspirates in children with acute bacterial sinusitis, and with the exception of acute maxillary sinusitis associated with infections of dental origin, 51 respiratory anaerobes are also rarely recovered. 40, 52. Although S. aureus is a very infrequent cause of acute bacterial sinusitis in children, it is a significant pathogen in the orbital and intracranial complications of sinusitis. The reasons for this discrepancy are unknown. Antimicrobial susceptibility patterns for S. pneumoniae vary considerably from community to community. Isolates obtained from surveillance centers nationwide indicate that, at the present time, 10% to 15% of upper respiratory tract isolates of S. pneumoniae are non-susceptible to penicillin. 53, 54. However, values for penicillin non-susceptibility as high as 50% to 60% have been reported in some areas. 5,556. Of the organisms that are resistant, approximately half are highly resistant to penicillin and the remaining half are intermediate in resistance. 535,456. 59 between 10% and 42% of H. influenzae. 56, 59 and close to 100% of M. catarrhalis are likely to be sharp S. lactamase positive and susceptible to amoxicillin. Because of dramatic geographic variability in the prevalence of sharp S. lactamase positive H. influenzae, it is extremely desirable for the practitioner to be familiar with low calorie patterns of susceptibility. Risk factors for the presence of organisms. Nonsense. F170 from the American Academy of Pediatrics, downloaded from www.applications.org/news. I967986 on January 40, 2019. From the American Academy of Pediatrics. Likely to be resistant to amoxicillin include attendance at child care, receipt of antimicrobial treatment within the previous 30 days, and age younger than 2 years. 5,055. 60. Amoxicillin remains the antimicrobial agent of choice for first-line treatment of uncomplicated acute bacterial sinusitis in situations in which antimicrobial resistance is not suspected. This recommendation is based on amoxicillin's effectiveness, safety, acceptable taste, low cost, and relatively narrow microbiologic spectrum. For children aged 2 years or older with uncomplicated acute bacterial sinusitis that is mild to moderate in degree of severity who do not attend child care and who have not been treated with an antimicrobial agent within the last 4 weeks, amoxicillin is recommended at a standard dose of 45 mg/kg per day in 2 divided doses. In communities with a high prevalence of non-susceptible S. pneumoniae 10%, including intermediate and high level resistance, treatment may be initiated at 80 to 90 mg/kg per day in 2 divided doses, with a maximum of 2 g per dose. 55. This high dose amoxicillin therapy is likely to achieve sinus fluid concentrations that are adequate to overcome the resistance of S. pneumoniae, which is attributable to alteration in penicillin binding proteins on the basis of data derived from patients with AOM. 61. Within the next several years after licensure of PCV13, a continuing decrease in isolates of S. pneumoniae, including a decrease in isolates of non-susceptible S. pneumoniae and an increase in B. lactamase, producing H. influenzae are observed. Standard dose amoxicillin clavulanate 45 mg/kg per day may be most appropriate. Patients presenting with moderate to severe illness as well as those younger than 2 years, attending child care, or who have recently been treated with an antimicrobial may receive high-dose amoxicillin, clavulanate 80-90 mg/kg per day of the amoxicillin component with 6.4 mg/kg per day of clavulanate in 2 divided doses with a maximum of 2 g per dose. The potassium clavulanate levels are adequate to inhibit all sharp S. lactamase producing H. influenzae and M. catarrhalis 5,659. A single 50 mg/kg dose of ceftriaxone, given either intravenously or intramuscularly, can be used for children who are vomiting, unable to tolerate oral medication, or unlikely to be adherent to the initial doses of antibiotic. 62-64. The 3 major bacterial pathogens involved in acute bacterial sinusitis are susceptible to ceftriaxone in 95% to 100% of cases. 56, 5,859. If clinical improvement is observed at 24 hours, an oral antibiotic can be substituted to complete the course of therapy. Children who are still significantly febrile or symptomatic at 24 hours may require additional parenteral doses before switching to oral therapy. The treatment of patients with presumed allergy to penicillin has been controversial. However, recent publications indicate that the risk of a serious allergic reaction to second and third generation cephalosporins in patients with penicillin or amoxicillin allergy appears to be almost nil and no greater than the risk among patients without such allergy. 65-67. Thus, patients allergic to amoxicillin with a non-type 1 late or delayed 72 hours hypersensitivity reaction can safely be treated with ceftonir, ceftriaxone, or ceftriaxone. 66-68. Patients with a history of a serious type 1 immediate or accelerated anaphylactoid reaction to amoxicillin can also safely be treated with ceftonir, ceftriaxone, or ceftriaxone. In both circumstances, clinicians may wish to determine individual tolerance by referral to an allergist for penicillin and/or cephalosporin skin testing before initiation of therapy. 66-68. The susceptibility of S. pneumoniae to ceftonir, ceftriaxone, and ceftriaxone varies from 60% to 75%. 56-59. And the susceptibility of H. influenzae to these agents varies from 85% to 100%. 5,658 in young children. 2 years with a serious type 1 hypersensitivity to penicillin and moderate or more severe sinusitis. It may be prudent to use a combination of clindamycin or linezolid and cefixime to achieve the most comprehensive coverage against both resistant S. pneumoniae and H. influenzae. Linezolid has excellent activity against all S. pneumoniae, including penicillin-resistant strains, but lacks activity against H. influenzae and M. catarrhalis. Alternatively, a quinolone, such as levofloxacin, which has a high level of activity against both S. pneumoniae and H. influenzae, may be prescribed. 5,758. Although the use of quinolones is usually restricted because of concerns for toxicity, cost, and emerging resistance, their use in this circumstance can be justified. Pneumococcal and H. influenzae surveillance studies have indicated that resistance of these organisms to trimethoprim, sulfamethoxazole, and azithromycin is sufficient to preclude their use for treatment of acute bacterial sinusitis in patients with penicillin. Hypersensitivity 56,585,969. The optimal duration of antimicrobial therapy for patients with acute bacterial sinusitis has not received systematic study. Recommendations based on clinical observations have varied widely, from 10 to 28 days of treatment. An alternative suggestion has been made that antibiotic therapy be continued for 7 days after the patient becomes free of signs and symptoms. This strategy has the advantage of individualizing the treatment of each patient, results in a minimum course of 10 days. In Pediatrics Volume 132, Number 1, July 2013. Downloaded from www.applications.org/news. I-96-7986 on January 40, 2019, F-471. Avoids prolonged antimicrobial therapy in patients who are asymptomatic and therefore unlikely to adhere to the full course of treatment. 5. Patients who are acutely ill and appear toxic when first seen see below can be managed with one of 2 options. Consultation can be requested from an otolaryngologist for consideration of maxillary sinus aspiration with appropriate analgesia/anesthesia to obtain a sample of sinus secretions for gram stain, culture, and susceptibility testing so that antimicrobial therapy can be adjusted precisely. Alternatively, inpatient therapy can be initiated with intravenous ceftriaxone or ceftriaxone, with referral to an otolaryngologist if the patient's condition worsens or fails to show improvement within 48 hours. If a complication is suspected, management will differ depending on the site and severity. A recent guideline was published by the Infectious Diseases Society of America for acute bacterial sinusitis in children and adults. 70. Their recommendation for initial empirical antimicrobial therapy for acute bacterial sinusitis in children was amoxicillin, clavulanate based on the concern that there is an increasing prevalence of H. influenzae as a cause of sinusitis since introduction of pneumococcal conjugate vaccines and an increasing prevalence of B. lactamase production among these strains. In contrast, this guideline from the AP allows either amoxicillin or amoxicillin, clavulanate as first-line empirical therapy and is therefore inclusive of the Infectious Diseases Society of America's recommendation. Unfortunately, there are scant data available regarding the precise microbiology of acute bacterial sinusitis in the post-PCV 13-year perspective. Surveillance of nasopharyngeal cultures may be helpful in completely aligning these recommendations in the future. Key Action Statement 5A. Clinicians should reassess initial management if there is either a caregiver report of worsening progression of initial signs/symptoms or appearance of new signs/symptoms or failure to improve lack of reduction in all presenting signs/symptoms within 72 hours of initial management evidence quality. C. Recommendation. A is Profile 5A. Aggregate evidence quality. C. Observational studies. Benefits. Harm. Cost benefits. Harm assessment. Value judgments. Role of patient preferences. Intentional vagueness exclusions. Strength. Bacterial sinusitis by 72 hours after diagnosis and initial management. Patients with persistent but improving symptoms do not meet this definition. The rationale for using 72 hours as the time to assess treatment failure for acute bacterial sinusitis is based on clinical outcomes in RCTs. Wald et al. 11. Found that 18 of 35 patients, 51% receiving placebo, demonstrated symptomatic improvement within 3 days of initiation of treatment. Only an additional 3 patients receiving placebo, 9% improved between days 3 and 10. In the same study, 48 of 58 patients. Identification of patients who may have been misdiagnosed, those at risk of complications, and those who require a change in management. Delay of up to 72 hours in changing therapy if patient fails to improve. Additional provider and caregiver time and resources. Preponderance of benefit. Use of 72 hours to assess progress may result in excessive classification as treatment failures if premature. Emphasis on importance of worsening illness in defining treatment failures. Caregivers determine whether the severity of the patient's illness justifies the report to clinician of the patient's worsening or failure to improve. 9. Patients with severe illness, poor general health, complicated sinusitis, immune deficiency, previous sinus surgery, or coexisting bacterial illness. Recommendation. The purpose of this key action statement is to ensure that patients with acute bacterial sinusitis who fail to improve symptomatically after initial management are reassessed to be certain that they have been correctly diagnosed and to consider initiation of alternate therapy to hasten resolution of symptoms and avoid complications. Worsening is defined as progression of presenting signs or symptoms of acute bacterial sinusitis or onset of new signs or symptoms. Failure to improve is lack of reduction in presenting signs or symptoms of acute, or 83%, receiving antibiotics cured or improved within 3 days. At 10 days, the overall rate of improvement was 79%, suggesting that no additional patients improved between days 3 and 10. In a more recent study, 17 of 19 children who ultimately failed initial therapy with either antibiotic or placebo demonstrated failure to improve within 72 hours. 4. Although Garbutt et al. 42 did not report the percentage of patients who improved by day 3, they did demonstrate that the majority of improvement in symptoms occurred within. F172 from the American Academy of Pediatrics, downloaded from www.applications.org/news by 967986 on January 40, 2019, from the American Academy of Pediatrics. The first 3 days of study entry, whether they received active treatment or placebo, reporting of either worsening or failure to improve implies a shared responsibility between clinician and caregiver. Although the clinician should educate the caregiver regarding the anticipated reduction in symptoms within 3 days, it is incumbent on the caregiver to appropriately notify the clinician of concerns regarding worsening or failure to improve. Clinicians should emphasize the importance of reassessing those children whose symptoms are worsening whether or not antibiotic therapy was prescribed. Assessment may be indicated before the 72-hour KS Profile 5B process by which such reporting occurs should be discussed at the time the initial management strategy is determined. The Action Statement 5B. If the diagnosis of acute bacterial sinusitis is confirmed in a child with worsening symptoms or failure to improve in 72 hours, then clinicians may change the antibiotic therapy for the child initially managed with antibiotic or initiate antibiotic treatment of the child initially managed with observation evidence quality. B. Option based on expert opinion, case reports, and reasoning from first principles. Aggregate evidence quality. D. Expert opinion and reasoning from first principles. Benefit, harm, cost. Benefits, harm assessment. Value judgments. Role of patient preferences. Intentional vagueness exclusion strength. Prevention of complications. Administration of effective therapy. Adverse effects of secondary antibiotic therapy. Direct cost of medications, often substantial for second-line agents. Preponderance of benefit. Clinician must determine whether cost and adverse effects associated with change in antibiotic is justified given the severity of illness. Limited in patients whose symptoms are severe or worsening, but caregivers of mildly affected children who are failing to improve may reasonably defer change in antibiotic. 9. Option. Mark if the patient is substantially worse, because it may indicate the development of complications or a need for parenteral therapy. Conversely, in some cases, caregivers may think that symptoms are not severe enough to justify a change to an antibiotic with a less desirable safety profile or even the time, effort, and resources required for reassessment. Accordingly, the circumstances under which caregivers report back to the clinician, and the purpose of this key action statement is to ensure optimal antimicrobial treatment of children with acute bacterial sinusitis whose symptoms worsen or fail to respond to the initial intervention to prevent complications and reduce symptom severity and duration. See Table 4. Clinicians who are notified by a caregiver that a child's symptoms are worsening or failing to improve should confirm that the clinical diagnosis of acute bacterial sinusitis corresponds to the patient's pattern of illness as defined in Key Action Statement 1. If caregivers report worsening of symptoms at any time in a patient for whom observation was the initial intervention, the clinician should begin treatment as discussed in Key Action Statement 4. For patients whose symptoms are mild and who have failed to improve but have not worsened, initiation of antimicrobial agents or continued observation for up to 3 days is reasonable. If caregivers report worsening of symptoms after 3 days in a patient initially treated with antimicrobial agents, current signs and symptoms should be reviewed to determine whether acute bacterial sinusitis is still the best diagnosis. If sinusitis is still the best diagnosis, infection with drug-resistant bacteria is probable, and an alternate antimicrobial agent may be administered. Phase 2. Phase reevaluation of the patient is desirable. Once the decision is made to change medications, the clinician should consider the limitations of the initial antibiotic coverage, the anticipated susceptibility of residual bacterial pathogens, and the ability of antibiotics to adequately penetrate the site of infection. Cultures of sinus or nasopharyngeal secretions in patients with initial antibiotic failure have identified a large percentage of bacteria with resistance to the original antibiotic, 71, 72. Furthermore, multi-drug-resistant S. pneumoniae and Sharp-S, lactamase, positive H. influenzae, and M. catarrhalis are more commonly isolated after previous antibiotic exposure. 73-78. Unfortunately, there are no studies in children that have investigated the microbiology of treatment failure in acute bacterial sinusitis or cure rates using second-line antimicrobial agents. As a result, the likelihood of adequate antibiotic coverage for resistant organisms must be Pediatrics Volume 132, Number 1, July 2013, downloaded from www.publications.org/news. 996-7986 on January 40, 2019, April 173. Addressed by extrapolations from studies of acute otitis media in children and sinusitis in adults and by using the results of data generated in vitro. General Guide to Management of a Child Who Worsens in 72 Hours is shown in Table 4. No recommendation. Adjuvant therapy. Potential adjuvant therapy for acute sinusitis might include intranasal corticosteroids, saline nasal irrigation or lavage, topical or oral decongestants, mucolytics, and topical or oral antihistamines. A recent Cochrane review on decongestants, antihistamines, and nasal irrigation for acute sinusitis in children found no appropriately designed studies to determine the effectiveness of these interventions. 79. Intranasal steroids. The rationale for the use of intranasal corticosteroids in acute bacterial sinusitis is that an anti-inflammatory agent may reduce the swelling around sinus posture and encourage drainage, thereby hastening recovery. However, there are limited data on how much inflammation is present, whether the inflammation is responsive to steroids, and whether there are differences in responsivity according to age. Nonetheless, there are several RCTs in adolescents and adults, most of which do show significant differences compared with placebo or active comparative that favor intranasal steroids in the reduction of symptoms and the patient's global assessment of overall improvement. 80-85. Several studies in adults with acute bacterial sinusitis provide data supporting the use of intranasal steroids as either monotherapy or adjuvant therapy to antibiotics. 81-86. Only one study did not show efficacy. 85. There have been 2 trials of intranasal steroids performed exclusively in children, one comparing intranasal corticosteroids versus an oral decongestant and the other comparing intranasal corticosteroids with placebo. These studies showed a greater rate of complete resolution 87 or greater reduction in symptoms in patients receiving the steroid preparation. Although the effects were modest 88, it is important to note that nearly all of these studies, both those reported in children and adults, suffered from substantial methodologic problems. Examples of these methodologic problems are as follows: 1 variable inclusion criteria for sinusitis, 2 mixed populations of allergic and non-allergic subjects, and 3 different outcome criteria. All of these factors make deriving a clear conclusion difficult. Furthermore, the lack of stringent criteria in selecting the subject population increases the chance that the subjects had viral URIs or even resistant allergies rather than acute bacterial sinusitis. The intranasal steroid study to date include busulfide, flunasalide, fluticasone, and mometasone. There is no reason to believe that one steroid would be more effective than another, provided equivalent doses are used. Potential harm in using nasal steroids in children with acute sinusitis includes the increased cost of therapy, difficulty in effectively administering nasal sprays in young children, nasal irritation and epistaxis, and potential systemic adverse effects of steroid use. Fortunately, no clinically significant steroid adverse effects have been discovered in studies in children. 89-96. Saline irrigation, saline nasal irrigation, or lavage not saline nasal spray has been used to remove debris from the nasal cavity and temporarily reduce tissue edema. Hypertonic saline to promote drainage from the sinuses. There have been very few RCTs using saline nasal irrigation or lavage in acute sinusitis, and these have had mixed results. 97-88. One study in children showed greater improvement in nasal airflow and quality of life as well as a better rate of improvement in total symptom score when compared with placebo in patients treated with antibiotics and decongestants. 98. There are 2 Cochrane reviews published on the use of saline nasal irrigation in acute sinusitis in adults that show variable results. One review published in 20-0799 concluded that it is a beneficial adjunct, but the other, published in 2,010,100, concluded that most trials were too small or contained too high risk of bias to be confident about benefits. Nasal decongestants, mucolytics, and antihistamines data are insufficient to make any recommendations about the use of oral or topical nasal decongestants. Mucolytics, or oral or nasal spray antihistamines as adjuvant therapy for acute bacterial sinusitis in children. 79. It is the opinion of the expert panel that antihistamines should not be used for the primary indication of acute bacterial sinusitis in any child, although such therapy might be helpful in reducing typical allergic symptoms in patients with API who also have acute sinusitis. Other related conditions. Recurrence of acute bacterial sinusitis. Recurrent acute bacterial sinusitis RABS is an uncommon occurrence in healthy children and must be distinguished from recurrent URIs, exacerbations of allergic rhinitis, and chronic sinusitis. The former is defined by episodes of bacterial infection of the paranasal sinuses lasting fewer than 30 days and separated by intervals of April 174 from the American Academy of Pediatrics, downloaded from www.publications.org/news. 996-7986 on January 40, 2019. From the American Academy of Pediatrics. Table 3 parent information regarding initial management of acute bacterial sinusitis. How common are sinus infections in children? How can I tell if my child has bacterial sinusitis or simply a common cold? If my child has sinusitis, should he or she take an antibiotic? Why not give all children with acute bacterial sinusitis an immediate antibiotic, at least 10 days during which the patient is asymptomatic? Some experts require at least 4 episodes in a calendar year to fulfill the criteria for this condition. Chronic sinusitis is manifest as 90 or more uninterrupted days of respiratory symptoms, such as cough, nasal discharge, or nasal obstruction. Children with RABS should be evaluated for underlying allergies, particularly allergic rhinitis, quantitative and functional immunologic defect S. Thick, colored, or cloudy mucus from your child. Most frequently occurs with a common cold or viral infection and does not by itself mean your child has sinusitis. In fact, fewer than 1 in 15 children get a true bacterial sinus infection during or after a common cold. Most colds have a runny nose with mucus that typically starts out clear, becomes cloudy or colored, and improves by about 10 D. Some colds will also include fever temperature 38 degrees C, 100.4 degrees F for 1 to 2 days. In contrast, acute bacterial sinusitis is likely when the pattern of illness is persistent, severe, or worsening one. Persistent sinusitis is the most common type, defined as runny nose of any quality, daytime cough which may be worse at night, or both for at least 10 days without improvement. 2. Severe sinusitis is present when fever temperature 39 degrees C, 102.2 degrees F lasts for at least 3 days in a row and is accompanied by nasal mucus that is thick, colored, or cloudy. 3. Worsening sinusitis starts with a viral cold, which begins to improve but then worsens when bacteria take over and cause new, until fever temperature 238 degrees C, 100.4 degrees F, or a substantial increase in daytime cough or runny nose. Children with persistent sinusitis may be managed with either an antibiotic or with an additional brief period of observation, allowing the child up to another 3 days to fight the infection and improve on his or her own. The choice to treat or observe should be discussed with your doctor and may be based on your child's quality of life and how much of a problem the sinusitis is causing. In contrast, all children diagnosed with severe or worsening sinusitis should start antibiotic treatment to help them recover fast and more often. Some episodes of persistent sinusitis include relatively mild symptoms that may improve on their own in a few days. In addition, antibiotics can have adverse effects, which may include vomiting, diarrhea, upset stomach, skin rash, allergic reactions, yeast infections, and development of resistant bacteria that make future infections more difficult to treat. Chiefly immunoglobulin and immunoglobulin G deficiency, cystic fibrosis, gastroesophageal reflux disease, or dysmethyl syndrome, 101, anatomic abnormalities obstructing one or sinus ostia may be present. These include septal deviation, nasal polyps, or conchabulosa pneumatization of the middle turbinate, atypical ethmoid cells with compromised drainage, a lateralized middle turbinate, and intrinsic osteometal anomalies, 102. Contrast, enhanced CT, MRI, or endoscopy or all three should be performed for detection of obstructive conditions, particularly in children with genetic or acquired craniofacial abnormalities. The microbiology of RABs is similar to that of isolated episodes of acute bacterial sinusitis and warrants the same treatment. 72. It should be recognized that closely spaced sequential courses of antimicrobial therapy may foster the emergence of antibiotic-resistant bacterial species as the causative agent in recurrent episodes. There are no systematically evaluated options for prevention of RABs in children. In general, the use of prolonged prophylactic antimicrobial therapy should be avoided and is not usually recommended for children with recurrent acute otitis media. However, when there are no recognizable predisposing conditions to remedy in children with RABs, prophylactic antimicrobial agents may be used for several months during the respiratory season. Enthusiasm for this strategy is tempered by concerns regarding the encouragement of bacterial resistance. Accordingly, prophylaxis should only be considered in carefully selected children whose infections have been thoroughly documented. Influenza vaccine should be administered annually, and PCV13 should be administered at the recommended ages for all children, including those with RABs. Intranasal steroids and non-sedating antihistamines can be helpful for children with allergic rhinitis, as can anti-reflux medications for those with gastroesophageal reflux disease. Children with anatomic abnormalities may require endoscopic surgery for removal of or reduction in osteometal obstruction. The pathogenesis of chronic sinusitis is poorly understood and appears to be multifactorial. However, many of the conditions associated with RABs. Pediatrics Volume 132, Number 1, July 2013, downloaded from www.applications.org/news. I 967986 on January 40, 2019, April 175. Table 4, management of worsening or lack of improvement at 72 hours. Initial management, observation, amoxicillin, worsen 72 hours. Initiate amoxicillin with or without clavulanate, high. Dose amoxicillin, clavulanate, high. Dose amoxicillin, clavulanate, clindamycin, and cefixime or linezolid and cefixime or clindamycin prefer. Levofloxacin, lack of improvement in 72 hours. Additional observation or initiate antibiotic based on share. Decision making additional observation or high. Dose amoxicillin, clavulanate. Based on shared decision, making continue high. Dose amoxicillin, clavulanate or clindamycin, and cefixime or linezolid and cefixime or levofloxacin. It's recommended to cover penicillin, resistant S pneumonia. Some communities have high levels of clindamycin, resistant S pneumonia. In these communities, linezolid have also been implicated in chronic sinusitis, and it is clear that there is an overlap between the two syndromes. 101,102 in some cases. There may be episodes of acute bacterial sinusitis superimposed on a chronic sinusitis, warranting antimicrobial therapy to hasten resolution of the acute infection. Complications of acute bacterial sinusitis. Complications of acute bacterial sinusitis should be diagnosed when the patient develops signs or symptoms of orbital and/or central nervous system intracranial involvement. Rarely, complicated acute bacterial sinusitis can result in permanent blindness, other neurologic sequelae, or death if not treated promptly and appropriately. Orbital complications have been classified by Chandler et al. 32 intracranial complications include epidural or subdural abscess, brain abscess, venous thrombosis, and meningitis. Periorbital and intraorbital inflammation and infection are the most common complications of acute sinusitis and most often are secondary to acute ethmoiditis in otherwise healthy young children. These disorders are commonly classified in relation to the orbital septum. Periorbital or perceptual inflammation involves only the eyelid, whereas postseptal intraorbital inflammation involves structures of the orbit. Mild cases of perceptual cellulitis eyelid 50% closed may be treated on an outpatient basis with appropriate oral antibiotic therapy high. Dose amoxicillin, clavulanate for comprehensive coverage for acute bacterial sinusitis and daily follow up until definite improvement is noted. If the patient does not improve within 24 to 48 hours or if the infection is progressive, it is appropriate to admit the patient to the hospital for antimicrobial therapy. Similarly, if proptosis, impaired visual acuity, or impaired and/or painful extraocular mobility is present on examination, the patient should be hospitalized. In contrast, enhanced CT should be performed. Consultation with an otolaryngologist, an ophthalmologist, and an infectious disease expert is appropriate for guidance regarding the need for surgical intervention and the selection of antimicrobial agents. Intracranial complications are most frequently encountered in previously healthy adolescent males with frontal sinusitis, 3,334, and patients with altered mental status, severe headache, or pus puffy tumor osteomyelitis of the frontal bone. Neurosurgical consultation should be obtained. In contrast, enhanced CT scan, preferably coronal thin cut of the head or orbits, and sinuses is essential to confirm intracranial or intraorbital subturative in complications. In such cases, travellous antibiotics should be started immediately. Alternatively, an MRI may also be desirable in some cases of intracranial abnormality. Appropriate antimicrobial therapy for intraorbital complications include vancomycin to cover possible methicillin, resistant S. aureus or penicillin, resistant S. pneumonia, and either ceftriaxone, ampicillin, sulbactam, or piperacillin-tazobactam. 103. Given the polymicrobial nature of sinogenic abscesses, coverage for anaerobes, i.e., metronidazole should also be considered for intraorbital complications and should be started in all cases of intracranial complications if ceftriaxone is prescribed. Patients with small orbital, superiosteal, or epidural abscesses and minimal ocular and neurologic abnormalities may be managed with intravenous antibiotic treatment for 24 to 48 hours while performing frequent visual and mental status checks. 104. In patients who develop progressive signs and symptoms, such as impaired visual acuity, ophthalmoplegia, elevated intraocular pressure 20 mm, severe proptosis, 5 mm, altered mental status, headache, or vomiting, as well as those who fail to improve within 24 to 48 hours while receiving antibiotics, prompt surgical intervention and drainage of the abscess should be undertaken. 104. Antibiotics can be tailored to the results of culture and sensitivity studies when they become available. Areas for future research. Since the publication of the original guideline in 2001, only a small number of high-quality studies of the diagnosis and treatment of acute bacterial sinusitis in children have been published. Ironically, the number of published guidelines on the topic 5 exceeds the number of prospective. F176 from the American Academy of Pediatrics, downloaded from www.applications.org/news. I 967986 on January 40, 2019, from the American Academy of Pediatrics. Placebo-controlled clinical trials of either antibiotics or ancillary treatments of acute bacterial sinusitis. Thus, as was the case in 2001, there are scant data on which to base recommendations. Accordingly, areas for future research include the following. Etiology. 1. We examine the microbiology of acute sinusitis in children in the post-pneumococcal conjugate vaccine era and determine the value of using neuropolymerase chain reaction-based respiratory testing to document viral, bacterial, and polymicrobial disease. 2. Correlate cultures obtained from the middle meatus of the maxillary sinus of infected children with cultures obtained from the maxillary sinus by puncture of the antrum. 3. Conduct more and larger studies to more clearly define and correlate the clinical findings with the various available diagnostic criteria of acute bacterial sinusitis, for example, sinus aspiration and treatment outcome. 4. Develop non-invasive strategies to accurately diagnose acute bacterial sinusitis in children. 5. Develop imaging technology that differentiates bacterial infection from viral infection or allergic inflammation, preferably without radiation. Treatment. 1. Determine the optimal duration of antimicrobial therapy for children with acute bacterial sinusitis. 2. Evaluate A-weight and C prescription strategy for children with persistent symptom presentation of acute sinusitis. 3. Determine the optimal antimicrobial agent for children with acute bacterial sinusitis, balancing the incentives of choosing narrow-spectrum agents against the known microbiology of the disease and resistance patterns of likely pathogens. 4. Determine the causes and treatment of subacute, recurrent acute, and chronic bacterial sinusitis. 5. Determine the efficacy of prophylaxis with antimicrobial agents to prevent RABs. 6. Determine the effects of bacterial resistance among S. pneumoniae, H. influenzae, and M. catarrhales on outcome of treatment with antibiotics by the performance of randomized, double-blind, placebo-controlled studies in well-defined populations of patients. 7. Determine the role of adjuvant therapies and histamines, nasal corticosteroids, mucolytics, decongestants, nasal irrigation, etc. in patients with acute bacterial sinusitis by the performance of prospective, randomized clinical trials. 8. Determine whether early treatment of acute bacterial sinusitis prevents orbital or central nervous